محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. We will resume our activity about hypertensive disease in pregnancy, and today we will talk about eclampsia. We will have to define the eclampsia in this lecture, and we will talk about the management of eclampsia and complication of eclampsia and the other entity related to eclampsia. What is the definition of eclampsia? Eclampsia is a new onset of tonic-clonic focal or multifocal seizures or coma in absence of other causative condition such as epilepsy, cerebral artery ischemia, and infarction or intracranial hemorrhage or drug use. The incidence of eclampsia is 2 to 3% of those with preeclampsia with a severe feature and 0 to 0.6% of those with preeclampsia without severe feature. And we will talk later on while we are going in this lecture, and you will identify that eclampsia can occur without high blood pressure, without proteinuria. As we are talking about HELLP syndrome can occur without high blood pressure and without proteinuria. And we will be able to identify those cases with high risk, hoping if we couldn't identify them, we will be able to manage them. When we are talking about complication of eclampsia, we know that eclampsia contributed significantly for maternal death. So it is increasing the maternal mortality. Not only mortality, but also morbidity with long-term consequences and short-term consequences. Talking about long-term consequences, eclampsia can impair memory. If there is a recurrent seizures, the patient may have impaired cognitive function, and uncorrected severe hypertension can lead to cytotoxic edema or infarction. When we are talking about short-term consequences, we are talking about severe maternal hypoxia, trauma, aspiration pneumonia, PRESS syndrome, and reversible cerebral vasoconstriction syndrome. Remember that aspiration pneumonia could lead to maternal death. So, in general, we are talking about complication of eclampsia. We are talking about a serious condition which enhancing and increasing maternal mortality and morbidity with serious complication. Posterior reversible encephalopathy syndrome, or what we are referring to as PRESS, is a range of clinical neurological signs and symptoms. So the patients might present with visual loss or deficit, seizures, headache, severe headache, altered sensorium, or confusion. The diagnosis of PRESS is made by MRI. So MRI, the presence of the vasogenic edema and hyperintensity in the posterior aspect of the brain is a diagnostic criteria. CT scan can be done, but MRI more specific and more sensitive. The treatment of a woman with PRESS and reversible cerebral vasoconstriction syndrome may include medical control of hypertension, anti-epileptic medication, and long-term neurological follow-up. Patients with reversible cerebral vasoconstriction syndrome. How we can identify these patients? We can identify these patients by signs and symptoms that typically include thunderclap headache, less commonly focal neurological deficit related to the brain edema, stroke, seizures, and it is diagnosed by MRI. MRI characterized by reversible multifocal narrowing of the arteries of the brain. Treatment of the woman may include medical control of hypertension, anti-epileptic medications, and long-term neurological follow-up. So in short summary, any patient presented with a neurological symptom should be excluded that she is having reversible cerebral vascular syndrome or PRESS. And the way to diagnose this is by MRI. Eclampsia. Can we predict eclampsia? This is a critical question. If we know that 20 to 38% of the patient, they didn't demonstrate the classical sign of preeclampsia, which is the hypertension, proteinuria, before the seizure episode, neither the neurological abnormality which is presented in preeclampsia, whereas only 78 to 83% proceeded with the classical sign of preeclampsia. They have hypertension, proteinuria, in addition to the premonitored sign of cerebral irritation like severe persistent occipital or frontal headache. The headache are believed to be reflected the development of elevated cerebral perfusion pressure, cerebral edema, and hypertensive encephalopathy. The headache by itself, it is a unique entity. So if the patient is having severe critical occipital or frontal headache, should be alert us as a critical sign, whether it is accompanied by blurred vision, photophobia, altered mental status, or not. What is the most common antecedental sign and symptom preceding eclampsia? Hypertension occurs in 75% of the patient, so it's considered to be one of the main signs which is occur in the patients. Headache. We have persistent frontal or occipital headache with thunderclap headache, occur in 66% of patients. Visual disturbances, occur in 27% of the patient. It can occur in several ways. It can occur in scotoma, loss of visual or cortical blindness. They can have blurred vision, diplopia, visual field defect like homonymous hymenopia, and photophobia. Right upper quadrant epigastric pain occur in 25% of the patients. Remember that right upper quadrant or epigastric pain should alert the physician to think about HELLP syndrome. Asymptomatic, 25% of the patients. On physical examination, neurological finding may include brisk deep tendon reflex, clonus. The visual perceptions deficits, visual proceeding deficits, altered mental status, memory deficits, and the cranial nerve deficits. We can predict that this patient they have eclampsia or they will have eclampsia by looking to the patients. Look to your patient. If they are delirium, they are not oriented to you. Sometimes the patients, they are talking in haphazard way. The other way, the patient is not concentrating. You ask her and she is not answering you. You ask specifically about a specific sign, and then you can predict that this patient, they will have eclampsia. So what is the characteristic of eclamptic seizures? There is difference between seizures occurring in eclampsia and seizures occurring in non-eclamptic patients. More or less, it is generalized clonic-tonic seizures at onset associated with abrupt loss of consciousness, associated with screaming. The muscles of the arm, leg, chest, and back become stiff, and the woman may begin to appear cyanotic during the attack. After approximately 1 minute, the muscles begin to jerk and twitch. An additional 1 to 2 minutes, the tongue may be bitten. The patient, she might have frothy, bloody sputum due to biting the tongue. The post-ictal phase begins once the twitching movements end, and most patients begin to recover responsiveness within 10 to 20 minutes after the generalized convulsion with no focal neurological deficits. When we look to this diagram, we can see that eclampsia occurring mainly in around 60% antepartum, 20% intrapartum, and 21% postpartum. Out of this 21% postpartum, 90% within 7 days, and we have 10% more than 7 days. The most common presenting symptom was headache, which is occurring approximately 70% of the patients. As we mentioned, the patient, they can having also another symptom of severe preeclampsia, including shortness of breath, blurred vision, nausea, vomiting, edema, neurological deficits, epigastric pain. Many women didn't have hypertension during the antecedent pregnancy. Differential diagnosis of eclampsia can depend on the gestational age. It can depend on the presence of neurological deficits, depend on the metabolic abnormalities, depend on the disorder associated with the pregnancy. We will tackle each point alone and will explain how we can differentiate between eclampsia with any of the following things. When we are looking to the differential diagnosis, if eclampsia occurred in less than 20 weeks of pregnancy, we have to think about molar pregnancy. We have to think about if the seizures is already not related to pregnancy. Is the patient she's having eclamptic fit before? Whether in the childhood, look back to the history, and you can predict the cause of eclampsia before 20 weeks of gestation. As we mentioned, persistent neurological deficits is not one of the criteria or one of the things which is occur with eclampsia. Patients after eclampsia, they are not supposed to have persistent neurological deficits. So if persistent neurological deficit exists, you have to look for another cause of eclampsia or another cause of seizures. It could be anatomical abnormalities, stroke, intracranial hemorrhage, brain mass lesion, toxins and metabolic encephalopathy, reversible cerebral vasoconstriction syndrome, PRES, thrombotic thrombocytopenia purpura, or central nervous system infection. Other causes could be metabolic abnormalities. Hypocalcemia, hyponatremia, hypoglycemia could precipitate seizures attack. Toxins like alcohol withdrawal and drug intoxication, infection like meningitis, encephalitis, and sepsis, and recent head trauma. Other disorder associated with pregnancy like thrombotic thrombocytopenia purpura and hemolytic uremic syndrome. We will cover this in separate lecture, the lecture of HELLP syndrome. We'll cover both HELLP syndrome, hemolytic uremic syndrome, and thrombotic thrombocytopenia purpura. What is the optimal treatment for eclampsia? What I advise that every department should run eclamptic drill, and this drill should include nurses, midwife, and doctor. How we are acting with the patient who is having eclampsia? The person who is witnessing the eclampsia should call for help. Prevention of maternal injury, it is one of the main aim of management of patients who is having eclampsia. Placement in the lateral decubital position will prevent the patient from aspiration. And administration of oxygens. Monitoring the vital sign, including the oxygen saturations. Only subsequently is attention directed to the administration of magnesium sulfate. So when you place the patient on the lateral side, put the tongue depressors or the mouth piece to prevent the aspiration and preventing the tongue biting. Administer the oxygen, and it should be coming in sequentially. So the people who is the leader, whether the physician or the midwife, she will initiate the thing, and the team who is coming after that subsequently will administer the magnesium sulfate and will measure the blood pressure, and if the patients require antihypertensive medication will be given. If convulsion recur, further 2 to 4 grams of magnesium sulfate could be administered IV over 5 minutes. We didn't advise to give another medications because other medication like phenobarbital or phenytoin will make the patients more drowsy and increasing the risk of aspiration. But if the patients have persistent epileptical or convulsion attack, you can add it like sodium imobarbital 250 milligram IV in 3 minutes, or thiopental or phenytoin 1.25 milligram IV at a rate of 50 milligram per minute. Remember, persistent convulsion require ICU admission and endotracheal intubations and assisted ventilations. So eclampsia, it is a condition where you have to call for senior anesthesiologists. Head image should also be considered because most of the cases refractory to magnesium sulfate therapy may proving to have abnormal finding in the brain image. Fetal heart changes during eclampsia. Remember, you shouldn't consider or concentrate too much on doing CTG during the attack of eclampsia because there is certain changes occur, and this could be doing the CTG could alter the actual resuscitation maximally how it's supposed to be done. So CTG can have any of the following: prolonged fetal heart rate deceleration. Fetal heart rate bradycardia may last up to 3 to 5 minutes post-convulsion, or tachycardia. Sometimes increase in uterine contractility and baseline tone, reduced variability, and maternal resuscitation is usually followed by the normalization of fetal tracing. So when you expect the fetal heart rate to be normal? In a reassuring pattern, with frequent recurrent deceleration for more than 10 to 15 minutes despite maternal and fetal resuscitation and intervention, suggested the possibility of an occult abruption. So 15 minutes after the attack of eclampsia, the CTG should go back to normal. In any situation where the CTG persistence despite good resuscitations to be abnormal, an action should be taken. Mode of delivery in eclampsia. Eclampsia is not an indication for cesarean section. Keep in mind, once the patient is stabilized, the method of delivery should depend on facts, such as gestational age, fetal presentation, and finding of the cervical examination. If the gestational age less than 30 weeks, the patient is not in active labor with unfavorable Bishop score, the failure rate of induction is high. So preferably to do cesarean delivery without further delay. But if the patients have a decade progress in labor, could allow him to continue labor even after an eclamptic seizure. Anesthesia consideration. Regional anesthesia become the preferable technique for women with pre-eclampsia with severe feature as well as eclampsia for labor and delivery. We know that general anesthesia carry more risk to pregnancy rather than the regional anesthesia, like aspiration, failure, intubation due to the pharyngeal edema, and stroke secondary to increased systematic and intracranial pressure during the intubation and extubation. Neuraxial anesthesia and analgesia are contraindicated in the presence of coagulopathy, and we are allowing to do safely epidural anesthesia without the risk of hematoma if the platelets count is 70,000 and more.